So I'll set the timer for 15 minutes and
Okay.
yep. Can you see the screen?
So I can see the screen, but
Yep.
it is a little bit blurred.
Blurred. Okay, I think that's the. Okay. Give me a moment. I think I'll just open the image in a different tab. How about now?
Yeah, it's better now. It's enlarged now.
Yeah. Is it better now?
Yes.
Yeah, cool. Okay, shall we start? Okay, I've started your timer.
Yes. Okay, I'm present with the chronologist radiograph of a mature skeleton. I'm looking for any obvious abnormality, which I'm not able to appreciate. I'm going systematically. I'm looking for any pneumothorax, which I'm not able to appreciate. The retrocardiac region appears normal. I'm comparing both sides of the both sides, just for looking for symmetry. Upper zone appears normal, middle zone appears normal, lower zones appear normal. I'm seeing some well-defined rounded. I'm seeing well-defined rounded opacities in the left lower zones.
You can ignore that. You can ignore that. Let me tell you, this patient had a history of cardiac surgery.
Okay.
Yeah.
Okay. Cardiac surgery. I'm looking for any features of mediastinitis, any air in the mediastinal space, which I'm not able to appreciate.
Patient is asymptomatic. Patient came for a routine screening.
Okay. Apart from that, I'm looking for the bones, which appears normal. Cardiac surgery. There is a calcified foci or clips in the overlying the left hilum, which could be post-surgical.
Okay, okay. We're talking about this?
Yes.
Okay. What do you think it is?
It could be a surgical clip or which I'm not able to I'm not able to
You want me
appreciate any of the surgical clips. It's
you want me to
just
zoom
a,
in? I've zoomed it up
yeah,
a little bit more. Can you describe it for me?
it is a radiopacity,
Okay,
well-defined all radiopacity with surrounding radiolucency.
correct.
Uh, Apart from that,
Okay. Are you aware what it could be? I mean, have you seen something like this before?
um, no, usually in a cardiac post-surgical patient, either could be any opacity could be either could be a leads or it could be any sternal sutures or any valves
Correct,
with.
correct. Any valves. So this patient had Eisenmenger syndrome, for which
Okay.
this valve was put. So can you connect and tell me where the possible valve could be?
Eisenmenger syndrome, this could be in the pulmonary artery or the pulmonary valve.
So in
It is
Eisenmenger syndrome, it's with shunt, right to left or left to right?
Eisenmenger syndrome. Actually, it is usually due to the reversal of the shunt, which is I'm not able to recall
No
just
problem.
the
It's
left
okay.
leg.
Okay. So whenever there is an increase in the pressure in um, the basically the flow is supposedly when there is increased pulmonary arterial hypertension, right? So
Yes.
the pressure is increasingly more on the right side, and the blood.
It will be right to left.
Yeah. So what happens in
Diaphragms.
the, yeah, what happens is, so what is a connecting vessel between them?
Like that could be this ductus arteriosus.
Okay. Okay. Yeah.
So
So
this could be ductus arteriosus. Flip or I'm
oh,
not sure.
no worries. Yeah, fine. Yeah. This is your next case. Are you able to see the
Yes,
okay.
I'm able to see an epiradiograph of
Yeah.
ankle and foot on left side of an adult patient. I am going systematically.
Yeah.
The distal bones of the leg, the are appearing normal. The navicular there's no obvious bone lesion. There is slight soft tissue swelling in the middle side of the ankle. I'm looking for any fractures along that side. I'm not able to appreciate any.
Okay.
I'm looking for any radiolucency anywhere in the visualized skeletal system,
Okay.
which
Okay.
I'm not able
What would
to.
you, no problem. So what would you like to do next?
May I know the history of the patient?
So this patient had a history of uh, something serious illness, which I cannot tell you, but then patient is on a screening for the same.
Okay. The patient, then I would like to evaluate it further. I would like to do an MRI or a lateral radiograph to look
Okay.
initially to look for
I
any.
have a lateral radiograph for you.
Okay, and I'm able to see some soft tissue swelling in the heel region, the heel and region, which could be a bandage, which I'm not sure. There's something outside the body also.
Okay. Yeah. It is not a bandage. There is a lesion there. So what do you think it could be? What are your differentials?
This could be there is something in the distal leg also, distal
Okay.
leg region also. So this could be it's in the subcutaneous location. This could be a fibroma, neurofibroma,
Okay.
if the history is relevant.
Yeah.
And able to see some collapse of the dome of the diaphragm, dome of
Okay.
the talus.
Yeah. Let's stick with the
Uh,
mass. Let's stick with the lesion. So you told
okay.
me it could be a neurofibroma, right? Like a peripheral nerve sheath tumor, like a neurogenic
Yes.
tumor. Anything else
Yes.
that can be a
Apart from
possibility?
that, could be a foreign body granuloma, which could have
Okay.
penetrated and formed a mass.
Okay.
Another another possibility could be it is not hypodense, which rules out lipoma,
You mean radiolucent? Yeah.
radiolucent.
Yeah. Lipoma. Yeah. Correct. So anything else?
The, mm, other than that, there is a slight radiolucent lesion, radiolucency around the
Around the
lesion.
correct. Correct.
Around the lesion. And
Mhm.
there could be another infections like mother foot, but there is no other lesions anywhere
Okay.
in the foot, which I'm not able to visualize.
Mm-hmm.
Uh, Other could be
Could you look at the
gastroscopy.
could you look at
Yeah,
the rest of the X-ray?
okay. Um, there is a possible uh, radiolucent line along the first toe, the proximal phalanx. Could
Mm-hmm.
be a fracture, but the cortex is intact.
Okay.
Another is the
Anything
dome of
else?
the talus. Of the talus, which appears slightly
Yeah, you
depressed.
can. Yeah, you can ignore the bones. Bones were fine.
Apart from that, there is increase in the heel pad thickness,
Okay.
which
Can you look at the
could
rest of
be
the
a
corners of the X-ray? Can you look at the rest of the corners of the X-ray?
the corners, distal leg. I'm able to see some soft tissue soft tissue density projected on at the corner
Correct.
and the distal leg.
So do you think they are of a very similar density
Yes.
compared to the lesion on the dorsum of the foot?
Yes, yes.
So now we are seeing two lesions. So what do you think,
Yes.
apart from infection, something else that you should be suspecting?
Two different lesions could be neurofibromas,
Mm-hmm.
or another could be
If I tell you that this patient had a history of cancer,
cancer, metastasis to these subcutaneous regions is
okay, what
rare, but
metastasis can present like this?
it can
I
be
have,
like, yes.
yep.
Okay. So it's a bone scan
Okay.
with it is a PET study which showing metabolically active lesions in the mid leg,
Okay.
distal foot could be femur,
Mm-hmm.
and in the area mentioned before, which is
Right.
the sole of the foot.
Okay.
And
So I'm just, yeah, you can ask for control and you can scroll through these images if you want.
ask for control. Where should I ask for
Yeah,
control?
you will have an option about if you click three dots on the top, you might see request control, I think.
Yes, I got it.
Yeah, yeah. Just click and scroll. You might have to go slow because it's a lot of slices. So just click and scroll slowly.
Okay, going from caudal to cranial. So on the left side, I'm able to see a soft tissue density, and I'm able to see a metabolically active lesion in the soft tissue plane extending till the tibia on the left side in the mid shaft region.
Okay.
I'm still going up.
Yep. I think, yeah, that would be enough. I just wanted you to see if it's to show you it's metabolically active. So, so what do you think? What are your differentials now? Now you saw an opacity and then it's showing uptake. You said infections, but what else can be another differential for this?
Could be a melanoma,
Okay.
which is a which can present in the subcutaneous and the cutaneous plane.
Okay. Any other differentials?
Any other differentials? I'm not able to find. Any soft tissue sarcoma could be also be a
Very
differential.
good. Yeah. Okay. Okay. What would you like to do next?
I would like to refer this patient to the sarcoma team to plan for a biopsy.
Okay.
And for further management.
Okay. Yeah. You can click and scroll through it and let me know what you think. This is your next case. Yeah.
This is the next case, right? Okay.
This patient has diffuse body pain.
Diffuse body pain. I am able to appreciate that there is T2. This is a whole body MRI scan in fluid sensitive sequence and fat suppressed. I'm able to, and I'm going through the coronal images slice by slice. So there is diffuse increase in signal, T2 signal in the muscles of the proximal lower limb and the and around the pelvic muscles and in the upper arm, it's able to visualize. So there is generalized diffuse increase in T2 signals in the visualized muscles. This could be myositis in that context.
Okay.
Any history of any bone, any muscular pain or anything for the patient?
Yeah, patient has complaints of diffuse body pain for a couple of years now.
Okay.
And
So
also
in this,
currently patient presented with breathlessness. So we took a CT for the same patient, and you can scroll through this and let me know what you see.
okay, I'm going through the HSCT chest of a patient in lung window, axial images. I'm able to appreciate there is diffuse reticular uh, reticulation in the bilateral lower lobes, predominantly the lower lobes. I'm not able to appreciate much in the upper zones or the upper lobes or the right middle lobe. So this is there is no obvious areas of honeycombing. There is no obvious features of pneumothorax. So in this patient who presented with diffuse pain and showing T2 hyperintensities in general in all the visualized muscles on MRI, and patient having lower zone increased reticulations, smooth reticulations in the bilateral lower lobes. My first, my primary diagnosis will be of a um, myositis with associated NSIP
What
pattern.
myositis? What myositis do you know about?
Myositis and could be scleroderma, which can cause.
So you said myositis is one of the differentials. So what are
Yes.
the other GI manifestations for this condition?
GI manifestation for myositis. Um, I'm not sure about GI
No
manifestations of
problem. No
myositis.
problem. Yeah, that's fine. You can leave the mouse. You can leave the mouse.
Okay.
I think, yeah, maybe this we will do this one more case and then we'll stop. Yeah, you can
Okay.
scroll through it and tell me what do you think.
Okay. So I'm present with an
Yeah,
coronal
so this
sections of
patient presented with left hip swelling. Yeah.
left hip swelling. Okay. So I'm provided with an axial with a coronal sections of contrast with a fat saturated uh, fluid sensitive sequence of the uh, lower abdomen, pelvis, and upper uh, and the proximal lower limbs. So I'm going through the images one by one. So I'm able to see a large T2, lobulated T2 hetero intense lesion in the pelvis. Able to see a visualize. I'm able to visualize a skull, and this could be a pregnant lady. This could be a case of pregnancy.
Okay. Keep
Uh,
scrolling to the end of the film. Keep scrolling to the end of the film.
Looking at the hip, so there is a T2, ill-defined T2 hyperintensity node in the right.
Keep scrolling. Keep scrolling
Uh,
down. Keep scrolling down.
there is bilateral uh, ill-defined linear T2 hyperintensity is noted in the bilateral subcutaneous region of bilateral hip and the proximal thigh and the buttocks.
So what do you
I'm
think?
going through them.
So what are your thoughts?
So pregnant female with undefined hyperintensity stress or
Any
T2
any
hyperintensity.
history? Any history that you want to elicit?
Um, any patient is any non case of any metabolic syndrome,
Okay.
diabetes or something.
Mm-hmm.
Apart from that, subcutaneous hyperintensities would be uh, not able to come out with any other differential. The patient is complaining of left hip pain, right?
Correct.
Pain. So this,
So what would you like to do next?
um, I would like to get a proper history of any previous similar illnesses or
Okay.
any, and I will do an ultrasound just to see what contains, what are the contents of this lesion or any other more information I can derive.
Okay. Okay. Yep. Okay. Thank you. Yeah. So,
Okay.
so yeah, I think you did fairly well. You came to a very sensible conclusions in most of the cases, which is good. And I think only the feedback I would tell you is maybe increase your speed a little bit.
Okay.
When I think, and I like the fact that you are trying to slow down and pick up the findings slowly, but then time runs out. So maybe you can increase your speed a little bit, but you're picking up all the findings and you are organizing your thoughts well and you're putting a very sensible diagnosis, which is good. Okay. So I think this was the first case. I think it was quite tough because this is a PDA device. And
Okay.
sometimes these devices, lines and tubes can come up in the exam. So I thought I'll show you one device. So this is a PDA device. Sometimes if you see something like a concentric ring with a central radiopacity, think about PDA device. So this patient had a prior history of cardiac disease, most likely Eisenmenger syndrome and so on. So they do a PDA closure with the device. And usually we do a screening of the X-ray to look for any migration of that device from the location. This is normally where it should be located. Okay. And so that's it. So for just for understanding that such a thing exists, I showed a case like this. This one you were spot on. You gave me a good set of differentials for a soft tissue mass in the leg. Often in X-rays, when you don't see in one view, feel free to ask for a lateral view before you go to the next modality. Sometimes you will
Okay.
see the abnormality, and always look at the corners. Don't get carried away by single lesion, because in this case we have another lesion, and then that completely changes your set of differentials. In this case,
Okay.
you gave me melanoma, you gave me sarcoma, and maybe you can always add a lymphoma to it. Okay, and also other
Okay.
metastatic deposits. But then this turned out to be melanoma. The nuclear scan showed uptake in the lesions that we saw in X-ray, and also there was inguinal lymphadenopathy along with it. Okay, so this was a case of
Okay.
melanoma. So sometimes they can show you melanoma like soft tissue lesions on an ultrasound or an X-ray, and then they can take you there and discuss nuclear and so on. So I think it would
Okay.
be a good idea to learn differentials of soft tissue masses in all the planes: intramuscular, subcutaneous, fat, etc.
Okay.
Yep. This one, you were spot on. It was myositis, but I would have been happier if you had specified it as dermatomyositis. So
Okay.
in under myositis, we have two entities, right? Dermatomyositis and polymyositis. The
Okay.
in dermatomyositis, as the name goes, the skin involvement will be there, but when it's only the muscles that are involved, it is polymyositis. Okay, and more
Okay.
of subcutaneous involvement is for dermatomyositis. Okay, and
Okay.
often it's associated with the usually interstitial pneumonia UIP pattern, where we saw this fibrosis with honeycombing and basal predominance, etc. Okay, so your approach was good. You came to a very correct diagnosis. My added question was, what are the GI manifestations? So esophageal dysmotility and dysphagia is very commonly associated with dermatomyositis. Do you know
Okay.
which part of the esophagus is involved in dermatomyositis, and why?
Uh, Proximal esophagus,
Correct. Why do you think so?
because it could be skeletal muscles more.
Yeah, yeah, correct. So dermatomyositis involves the striated muscles. Okay, so it's always involving the pharynx and the upper esophagus. On the other hand, the reflex disease is associated with lower esophagus. So So always remember, so that's very striking thing that you should be noticing. The lower esophagus will be completely normal in such cases, but upper esophagus is where you should be targeting, right? So that was a case of dermatomyositis. Then I think I showed you this case. So this was a patient who had multiple silicone injections for gluteal enhancement. So
Okay.
this is a silicone injection. So what happens on long term? Sometimes these silicones can disintegrate, and then it can go enter into the bloodstream and cause embolism, or it can cause cellulitis or granulomas. So probably in
Okay.
this case, also patient might have developed a granuloma and associated pain. So I just
Okay.
showed you because um, when I give my exams, also a lot of candidates told me that they are giving a different forms of silicone injections in the breast as
Okay.
well as in the breast and gluteal region, and silicone leak in MR when with extracapsular rupture, which I got as a case once. So I think that is one of their favorite topics. So that is why I thought I'll show you one of the case related to it. Okay, but then
Okay.
I don't expect it to come, but then if it comes, then it should not be a curveball. So that's the only point. But otherwise, I think you did extremely well. All the very best. I think you're for the September, right?
Yes. Yes.
Yeah, all the very
Everything.
best, Jacob. Yeah, all the very best. Thank you so
Thank
much
you.
for attending with us. Yeah, bye.
Thank you.
Yeah. Candidate B, are you there?
Yes. Hello, can you hear
Yeah,
me?
yeah, I can hear you. I can hear you. Just a sec. Okay, are you able to see the screen?
Yes.
Yeah, great. Let's go.
I'm presented with the frontal radiograph of chest of a skeletally mature patient. Here I can see that there are reticular opacities seen in bilateral lungs, predominantly in the middle and the lower zones with relative central predominance. Also, I can see that there is some volume loss in the bilateral lungs, predominantly in the lower zones. And this is seen as flattening of the bilateral hemidiaphragms. As well as I can see that the cardiac margin is not well visualized. There is some saluting of the cardiac margin as well. There is gross cardiomegaly, though this appears to be a AP radiograph, but still I can see that there is some cardiomegaly. And the trachea appears deviated to the right side. I think that there's a fibrotic band that is extending into the right upper zone, causing this appearance. Apart from that, I think the bilateral hyla, they appear a bit bulky, but again, the volume is low, respiratory volume is low, so that could be artifactual. The left CP angle is blunted. I suspect that there might be some pleural effusion or pleural thickening here. Apart from that, I can see that there's some irregularity in the ribs. Could be some old heel fractures, but
Which
I'm
side?
not sure.
Which side? Which side?
On the left side, they appear a bit wavy to me on especially this fourth left rib.
Okay.
It could be a old heel fracture here, but I'm not sure. I have to correlate on the orthogonal
Yeah,
views.
no, you're right. You're right. There is healed. So patient had a history of major accident couple of years back. So probably because of that.
Okay. So apart from this, they know the significant findings. So in this patient who's in this X-ray, these findings make me think of some fibrosing interstitial lung disease leading to volume loss in the lower lungs. That is my first possibility. I cannot see any pleural plaques, any calcified pleural plaques to suggest asbestosis. So my possibilities would be an interstitial lung disease, a fibrosing interstitial lung disease like a usual interstitial pneumonitis or a non-specific interstitial pneumonitis. And I would refer this patient to the inform the findings to the referring clinician and refer this patient to the respiratory physicians for further review and compare with any previous radiographs to see for the progression of the disease. And suggest a contrast for HRCT of the chest to further characterize the findings. And discuss in the lung MDT meeting as well, lung ILD meeting as well.
Can you look
Also,
at your...
because there's some cardiomegaly, so I would suggest a echocardiogram. Yes.
Yeah. Could you have a look at your review areas one more time?
So I'm looking for, so there is some density that I can see in the right upper zone. Some reticular opacities are also seen in the right upper zone. I'm looking for any rib fractures apart from the ones I already mentioned. There are no lesions within the bones. Again, there's no pneumoperitoneum. So I think there is some cardiomegaly. So and there is some density that seen over the retrocardiac region here. So I'm suspicious there might be some nodule here, some
Where?
lesion
Can
here.
you ask
So
for control? Can you ask for control and show me?
yes. Okay.
Yeah, go ahead.
So I think that there is a retrocardiac nodule
Click
seen in the.
once. Click once. Click once. Yeah. Okay. Okay.
There's a retrocardiac density seen in the left para-aortic region. This could represent a suspicious lesion. I would be suspicious for it if the patient had any history of fever. This would represent some infection, like a bacterial or a tubercular infection. But if the patient had no such history, it could be neoplastic, or it could represent some vasculitic type pathology if the patient had such history prior, and I would further investigate for it. Also, because the heart is enlarged, so I'm also keeping a differential of some cardiogenic pulmonary edema, though I do not see any curly V lines, definitely, and any blunting of the CP angle. But because the heart is enlarged, so there might be some interstitial type pulmonary edema as well. So that would also be my differential here. And again, then infections would be there, could be superimposed infections. Apart from this, I'm able to see this density here, linear density. I don't know if it's significant or it's just projectional. There is some opacity overlying the left rib here. It could be a some fracture associated, because the patient has already had some fracture. It could be some fracture associated change, some calcified hematoma, pleural hematoma, extrapleural hematoma.
So what would you like to do next?
I would next like to investigate this patient with the help of a contrast enhanced CT of the chest to characterize all the findings.
You can leave the mouse once again. Yeah. Yeah, you can you leave the mouse? Yeah, one second. Yeah, okay. So this is the CT for you. You can scroll through it and let me know what you think.
Okay, so I'm presented with this contrast enhanced CT of the chest in axial windows. Here I can see that in the mediastinum, there's no significant lymphadenopathy. There is mild cardiomegaly. Apart from this, I'm able to see multiple nodules along the left hemithorax predominantly, and they're located in the predominantly along the posterior hemithorax with some pleural effusion. Some of them show internal calcifications. So these nodules have a broad base towards the pleura, which makes me think of pleural-based nodules. Some of them are also extending into the extrapleural space as well.
What are your differentials? What are your differentials?
So in this patient who has previously presented with trauma, I would be thinking first in terms of splenosis, because the density also appears similar to the spleen. Other possibility could be that of hematoma, organizing or residual organized hematoma, because the patient has had previous fractures in the rib. Also, these could be, these are my primary differentials, and I would to confirm my findings, I would recommend a nuclear scan, like a sulfur colloid scan, to further confirm these findings, and would inform my findings to the referring team. And also refer this patient to the gastroenterology department for further, or the hepatobiliary department for further evaluation. Thank you. And discuss in the MDT meeting regarding the further course of management. In my routine practice, I would also look at the lung windows and the bone windows to see for other findings as well, which might be helpful in this patient's management.
Okay. So
Thank you.
if the surgeon, if the patient is concerned that should this nodule be removed in the chest, and now you think it could be splenosis, right? So
Yes.
should it be removed?
Need not be removed, because if the patient is asymptomatic, I do not think that this would cause any problem. In fact, it would protect the patient from subsequent pneumococcal infections. So I would recommend that this should not be removed, and patient continue like that, especially if the patient has no symptoms because of it.
Okay. Okay. Yeah. You can click and scroll through the images.
Okay, I'm just going to scroll these images once before commenting. Okay, so these are the T2-weighted non-fat sat sequences, not T2-weighted non-fat sat sequences. Sorry, there's some. Yes, so these are the T2-weighted non-fat sat sequences in axial view of MRI abdomen. Actually, there's some lag. I'm not able to scroll smoothly.
Yeah, yeah, you can go slowly, then you wouldn't
Okay.
feel bad.
So in the imaged, in my first scroll, I could see that there was some there is some hypointensity within the gallbladder with layering, could represent represent gallbladder sludge. I'm not sure whether there is some edematous changes around the gallbladder. I would have to confirm that on the fat suppressed sequences. And there is some intrahepatic biliary duct dilatation as well. And there is a similar hypointensity, T2 hypointensity, that I can see within the bile duct. The proximal part of the bile duct appears prominent, but distally it shows tapering. Apart from that, I see that the spleen appears grossly normal. The pancreas and the rest of the visualized organs appear normal. So in my routine practice, I would see the fat suppressed sequences to look for any edema, any
Yeah,
inflammation.
this is the fat
So
suppressed.
these are the fat suppressed sequences where I see that there is some inflammatory changes within the gallbladder wall. There is also a focal lesion, T2 hypointense lesion within the liver parenchyma on the right lobe of the liver. Apart from this, no other lesion is seen in the liver. The gallbladder shows inflammatory changes. There is mural thickening and surrounding fat stranding and fluid. However, there is no evidence of any collection seen around the pericholecystic region. I'm just going to see for any changes within the liver, mild parenchymal hyperintensity, suggestive of some inflammatory changes are seen in the liver, but I cannot see any surrounding collection. So this wall thickening is circumferential. There are no focal areas of thickening that I can see, which would point towards a focal lesion. Though there is some soft tissue associated with this lesion, which is extending inferiorly, which I think is extending inferiorly towards the hepatic flexure. In my routine practice, I would confirm that on the coronal or some
Okay,
orthogonal planes.
I can give you the coronal. Yeah, can you leave the mouse once?
Mm.
Yeah, here you go.
These are the coronal T2-weighted fat sat sequences in which I see that the gallbladder has maintained fat planes with the liver. There is a hypointense focus within it, suggestive of calculus. And I think the fat planes with the there is some soft tissue seen at the level of the gallbladder neck. There is some soft tissue seen at the level of the gallbladder neck. Apart from this, there's no other significant finding. The margins with the hepatic flexure appear maintained. So in summary, I'm not seeing any CBD dilatation of the biliary duct. I'm not seeing any significant
Are you sure?
nodes
Are
in
you
the
sure?
abdomen.
You did mention there was intrahepatic biliary duct dilatation.
Intrahepatic biliary duct dilatation is there, but I could not see any dilatation of the biliary tract. I would confirm that on the, okay, there is some dilatation of the biliary duct. I would also confirm that on the MRCP images in my routine
Okay.
practice. I would also look for the nodes.
Yeah, I can give you the MRCP sequence here.
So on the MRCP sequence, I see that, okay. In MRCP sequence, there is, right, so there is some dilatation of the intrahepatic biliary ducts with a kind of a smooth cutoff that is seen at the level of the hilum, and the distal duct appears normal in caliber. So I think there might be some, as I saw, there was some soft tissue at the region of the gallbladder neck and the liver hilum, which could be causing these appearances. And there were no significant lymph nodes or any deposit seen in the peritoneal cavity. And there was a lesion in the liver, but it was hypointense on the T2 weighted images. So I do not think that would be very significant, though I would certainly evaluate on other sequences as well. So in summary, there is a soft tissue at the liver hilum, the portal at the porta and the liver hilum, which is involving the gallbladder neck as well as involving the proximal CBD. So it could be neoplastic, or it could be an inflammatory soft tissue, like because of IgG4 associated disease, but they are generally more circumferential and more long. If the patient had any surgery previously, then it could be a post-operative change as well. So in my routine practice, I would correlate with the patient's history, inform the findings to the referring team, correlate with the previous history of any surgery or any known malignancy, any ultrasound scans if they're available for correlation. And I would inform the findings to the referring team and refer this patient for further evaluation to the gastroenterology and the hepatobiliary teams for further management.
This is your next case.
And
Yeah. Yeah, that's fine. Yeah, you can scroll through it and let me know what you think.
So this is the MR T1 weighted images of the foot of a patient. I'm just going to scroll once to see the findings. So in this, I can see that there is some loss of the marrow signal, normal T1 marrow signal at places along multiple bones, especially seen in the metatarsal, fifth metatarsal, as well as I could see it the fifth metatarsal mainly, though these are sagittal. I mean, these are the axial images, and it would be a bit fallacious to look at them because the joint also is interposed in the same plane. So in my routine practice, I would look at some other plane like an axial or a coronal to further confirm. But there is some loss of normal marrow signal and cortical signal at the level of the fifth metatarsal, especially. The phalanges also. Some of the
what are your
phalanges,
differentials? What are your differentials?
So I think that this could be a infective lesion, seeing that the way it is involving the cortex and some fat stranding it is causing. It could be an infective lesion here. It doesn't look like a metastasis because they would be more focal, and looks like an infective lesion or a metabolic, something metabolic, which could be causing some loss in the normal marrow signal. In my routine practice, I would see other sequences as well to look at the signal.
Which sequence do you want to see?
I would look at the STIR sequence, the fat suppressed fluid sensitive
Unfortunately,
sequence.
we don't have. Can I show you T2?
Yes, sure.
Yeah, can you leave the mouse once?
Thickening along.
Yeah, can you leave the mouse? Yeah, one second. Yeah, this is the T2 for you.
Okay. So on the T2 weighted sequences, you can see that the fifth metatarsal shows altered signal intensity, which is T2 hyperintense, showing marrow edema, and there are multiple focal. There's also thickening of the skin, which is T2 hyperintense, and there's a nodular area of altered signal intensity, mixed signal intensity that I can see along the plantar aspect of the foot. And then it is continuing as some tubular channels along the plantar aspect of the foot with some fluid levels, I think. So my possibility in this case would be first a vascular lesion of a vascular origin, the morphology of the lesion, like multiple tubular channels and the fluid levels that I can see would correlate with that. Also, the bone involvement is more focal and joining the lesion would correlate. Another possibility could be some infiltrative tumor malignancy like a synovial sarcoma, but the appearances are actually not very typical of a synovial sarcoma. It is not mass-like, it is more of an infiltrative tissue. Another possibility could be some cystic, some lymphangioma as well, because it is infiltrating multiple spaces. So I would next to a MRI, contrast enhanced MR angiography to further characterize these lesions. Whether I cannot see any flow voids in them, so I suspect that this would be a low flow vascular malformation like a venous or a lymphatic malformation, but a contrast study with angiography would be helpful in characterization, and also to look for the proximal involvement of this lesion.
What information on CT can let me know if it's a slow flowing malformation?
On CT, there will be progressive enhancement. If it's a venous malformation, it will show progressive enhancement in the venous phase.
Let's say let's say the technician could not do a proper protocoling of the sequences. What other information can help me to think that it could be a slow flowing
There
malformation?
any plebolyts seen on the CT or on the radiograph that will help in correlating with that, or
Okay. Yeah. This is your next case, last case.
So presented with the frontal radiograph of chest of a skeletally mature patient, I can see a pacemaker wire in situ, which is appropriately positioned. It is a dual, sorry, the images suddenly got a little blurred. I don't know.
One sec.
So
1 minute, 1 minute, 1 minute.
Oh,
Is it better?
yeah, it's better. I don't know.
I'll just, yeah. Is it better now?
Yeah, it's better.
Yeah.
So there's a dual pacemaker, dual lead pacemaker, dual chamber pacemaker in situ. I can see a mitral valve replacement device in situ. There's some reticular opacities, coarse reticular opacities that are seen in the left hemithorax with some volume loss in the form of ipsilateral tracheal shift and diaphragmatic upliftment. And the mediastinum is also, the heart is also shifted towards this side. There are evidence of stenotomy sutures in situ, and I can see some air focus below the diaphragm. There's some air below the diaphragm. I'm not think it might be a pneumoperitoneum. I would have to confirm on the radiographs of the abdomen as well to see for the further extension of this lesion, whether it is within the bowel loops or whether it is in free air, but it would be a concerning finding and I would make a note of it. Apart from this, so there is volume loss in the left hemithorax and the right hemithorax appears relatively preserved. The hyla appear normal, so I'm suspecting that this might be a case of, but I do not see any hilar clips, any evidence of clips on the right hilum to suggest any post-operative changes. But it could be a case of lung transplantation. It could be a case of previous lung disease with unilateral lung transplantation, seeing that they're predominant in the left side, or there could be some unilateral fibrosis. Apart from this, I'm looking at the bones to look for any findings. So I do not think that there is. I would, for the correlation, I would ask, I would correlate with the, discuss this case with the clinician and ask them whether the patient had recently had any surgery that would explain this abnormal air focus in the under the diaphragm. If there has been no previous surgery and the patient has some symptoms, then I would raise a concern for this. I would urgently inform the referring team that of this pneumoperitoneum and suggest a contrast enhanced CT of the abdomen to further characterize the findings. And as for the lung pathology, I would correlate with the previous radiographs to see whether there has been a previous surgery done and what was the distribution of the disease previously. Was it unilateral from the beginning? In that case, I would think of some pathologies like maybe a Stewart-James syndrome with superimposed infection that could have led to such finding, or could be aspiration changes or some post-traumatic changes that could have led to this finding. Otherwise, it could be a case of single lung transplantation. So I would compare the previous radiographs in this case and then further evaluate this patient. Also discuss with the clinician regarding the current presentation. That would help me in further evaluating this patient better.
So, if you think it's an underlying interstitial lung disease, could you tell me the possible etiology in this case? What would have caused the interstitial lung disease?
I would compare the previous radiographs to see whether it is a unilateral lung disease or a bilateral. If it
Let's
is
assume
bilateral,
let's assume that this patient had bilateral interstitial lung disease. With the available image, can you come to a possible etiology for it?
so if it was a unilateral, then I can see multiple cystic lucencies within and it is diffusely distributed. So it could be something like a Langerhans histiocytosis or
No,
maybe
there is some information on the image that can make you think, okay, this could be a possible etiology for it.
could be amiodarone because the patient has a pacemaker in situ. So amiodarone toxicity can lead to such changes. And then
So this patient, this was a CT.
okay, so we just scroll once. So I can see that the right lung is shows some mosaic attenuation, but there are no significant nodules or any consolidation here. In the left lung, the lung volume is significantly reduced and it is replaced by honeycomb changes.
Okay, what are your
Also, I
differentials?
would, so my differentials would be, again, I would look at the mediastinal window to look at the attenuation of the liver. It is hyperdense. It could be a case of amiodarone toxicity, or it could also be, again, it could also be a interstitial disease like a usual interstitial pneumonia or something like very advanced sarcoidosis.
That would explain the left lung. What about the right lung? What's happening with the right lung?
The right lung presently has just some changes due to some altered hemodynamics because the left lung is collapsed. So the changes would represent something like a perfusion changes. It would not be pathologic, though I would look at the mediastinal window to see whether any pulmonary hypertension has set in. So in that case, it could also be because of pulmonary artery hypertension or some air trapping. I would do a expiratory CT for that, but I do not see any bronchiectasis or any nodules.
This is the expiratory CT for you.
So in the expiratory CT, okay. So I think there is some air trapping. So the possibilities could be a bronchiolitis if the patient has any history of pigeon exposure or some organic dust exposure. It could also be due to hypersensitivity pneumonitis, or it could be a case of respiratory bronchiolitis. In a lung transplantation patient, they have a tendency for graft versus host disease. So it could be due to obliterative bronchiolitis. And then again, hypersensitive pneumonitis and pulmonary hypertension could all,
Okay.
sorry, not pulmonary hypertension, basically these two differentials.
That's fine. That's fine. Yeah. Yeah. Okay. Thank you so much. How do you think you performed?
Not yet polished.
I personally felt you did well, but then is there striking problem with your presentation that you felt?
Not being able to correlate.
No, I think you have to draw a line where you have to stop.
Yeah.
You keep talking, and so what happens is examiners would not stop you. They will let you talk, and your time will run by. Here, I had to keep timer, and your 15 minutes is long done. So the fact that I thought I would try to show more cases rather than keep with timers, so that's the reason why I did not stop you. But the fact is, you have to keep a check on your timer. You have to know where to draw a line and stop, because you, for the X-rays and for the CTs, you keep talking. I agree that they think that you would know a lot of stuff about it, but when you keep talking and do not give a pause, you are not giving an opportunity for the examiners to ask you a question, and that's where the mark comes from. So
okay.
you will
So
have
means
to
I should pause in my description or should I pause after description? I don't
you have to
really.
pause during your description, and you will have to bring your description length a lot more down.
Right.
Maybe in the first 5 seconds, consolidate your ideas and then describe it very slowly with a small pause in between, so that lets the examiners come into your discussion and gel with your discussion. So now what
Right.
happened is I had to literally wait for you to end to ask questions, and that was never ending. So otherwise, your theoretical knowledge is good and you picked up all the findings with all cases. But I feel this might come a big problem for you in the exam. You have to slow down a bit. Yeah, I think it might
Do
come.
have
Yeah, it might come
lot
across
of
to the
people have
examiner.
told me that.
Yes, yes. I think it might come across to the examiners as a person who wants to rush through things. And that's what there are a lot of examiners who will want to ask you questions of why you think so. So I think slow down a bit, don't rush through it, and don't repeat things. I think you already said you will check with prior radiograph, and again towards the end you're saying the same thing. And you don't need to summarize towards the end. You already described everything, right? In summary, you say these are the things I think of. That's it. You don't have to tell all
Only
the
the only
findings.
the only the diagnosis.
Only the diagnosis. You don't have to tell all the summary things again because time is very valuable, right? Yeah.
Yes.
Yeah. Please take it as a positive thing. Otherwise, you're good. It's
Yes.
just that you have to control your time. Okay. So I think this was the first case I showed you, and um, it was this. Yeah. So this was a case of thoracic splenosis. You were right. But please look at your review areas. You cannot afford to miss the opacities which are seen in the retrocardiac region, because this can also be a malignancy, right, with lymphangitis carcinomatosis. And if you don't raise such a possibility, because you already mentioned there is reticular opacities, now you're seeing a mass in the retrocardiac region, but that word did not come from you that this could be a lung mass with lymphangitic picture in the background of reticular opacities. You spoke about vasculitis, you spoke about consolidation, in fact, right? So, but then when I gave you CT and you picked up, actually, I gave you the history very subtle about trauma, but then you stuck with that information, and you uh, brought out the history of splenosis, which is good. And you also went ahead and recommended for a specific nuclear scan that would confirm the diagnosis for splenosis. And you do not remove such spleens because patient can be risked for post-splenectomy sepsis. Okay, so you don't remove it. This was actually not a mass. There was a stone which was compressing on the CBD. If you go very slowly at the level of the, I think in this T2 axial T2, you asked for fat set, right? Yeah. So if you focus here at this level, there was a stone.
Yeah.
Yeah. And then if you look at this sequence, there was a smooth tapering. So the moment you said smooth tapering, you should have excluded malignancy, right? That's the difference between benign versus malignant structure, right? So there is no shouldering also to think, and there's no irregularity along the margins of it as well. So this was a case of a stone which is compressing over the CBD. Do you know the name of the syndrome?
Mersey's syndrome.
Yeah, this was a case of Mersey syndrome. Okay. So that was it. And this was a case of a vascular malformation, slow flowing vascular malformation. I did not waste time showing you the contrast, but then this was the contrast. And then DSA was also done, which showed blush entire sole of the foot.
So like if I'm able to make like on the T2, I say ki it's a vascular malformation. So should I ask for contrast to confirm, or should I?
No,
It will depend on the examiner.
So my strategy was, if I were in your place and I saw the T2-weighted sequence and I describe it and I tell them that I think it's a slow flow malformation, in my routine practice, I would also look at the post-contrast sequence and DSA, which would show me multiple flow voids, which is slowly enhancing or which is slowly taking up contrast on subsequent injection. So you tell them what you're going to see rather than you asking them, can you show me? Thereby you're saving your time. And second, it kind of gives them an information that you know what you're talking about.
Right.
This case was a case of bronchiolitis obliterans, okay, post-transplant rejection. Here you're seeing mosaic attenuation, and the area of low attenuation, the vessels are attenuated, showing oligemia. Okay, so air trapping with oligemia is a classic appearance for bronchiolitis obliterans. I like the fact that you picked up the in possibility of lung transplant. Okay, sometimes they can give you this and they can extrapolate it to amiodarone toxicity, which is very common. So please try to think of those connections before someone asks you. You could put that possibility forward. That if this
Right.
patient is on a long history of amiodarone, I would be concerned if this patient has a possible toxicity because of amiodarone. Okay,
Yeah.
correct. So I think that's it. I didn't show you this case, I guess. Did I show you? Yeah, I showed you. Okay, I had shown you the same thing. Yeah. Okay. Thank you so much, Varsha. All the very best.
Thank you so much.
Yeah. Bye.
Bye.
Yeah. Candidate 3, are you there?
Yes, sir.
Yeah. Hi. One sec. Yep. Can you see the screen?
Yes, sir. I can see the screen.
Yeah. One sec. Just give me a moment. Yeah. You can start. Yeah. You can start.
Okay, I'm presented with a frontal radiograph of a frontal chest radiograph of a skeletally mature patient. The first thing I notice is there is abnormality in the posterior ribs on the right side. I'm just trying to count the ribs.
You can ignore the ribs. Yeah.
The 6, 7, and 8. Yeah.
Yeah. Those are
I
old
have
heel
to ignore
fractures.
the
Yeah.
ribs. Okay, old heat fractures of the ribs. Okay. Okay, I do see there is some nodular opacities in bilateral lung fields, reticulonodular opacities in bilateral lung fields involving the mid and upper zones. The cardiac margins appear normal. Bilateral hyla also appear normal. There is no evidence of lymphadenopathy or bulkiness in the hyla. I'm just looking for any evidence of masses. Okay, I do not see any evidence of lung masses. Bilateral CP angles are clear. The cardiac margins are normal. Mm, Okay, so there are reticulonodular opacities in bilateral upper and mid zones. I think this could be there is no lymphadenopathy, but I would think of sarcoidosis. I would also think of tuberculosis. There is no evidence of bronchiectasis as well. I would like to proceed with the HRCT for this patient.
Anything else that you see classically abnormal in this X-ray, or anything abnormal that you see apart from all that the findings that you described?
The heart appears slightly tubular and lung volumes are slightly more. Maybe this could be a background COPD patient.
Okay.
But,
Anything else?
mm,
What
mm,
apart from COPD can show this morphology?
mm, increased lung volume. Okay. I'm not sure, sir.
Fine. That's
You
fine. No
just
problem.
check
What would you what would you like to do next?
I wanted to do a HRCT thorax for this patient.
Okay. Yeah. This is your you can control, you can ask for control and you can
Okay.
stop.
Requested. Okay. So this is a spot image, I guess. It's not scrolling. No. Yeah, it's scrolling. I'm not able to scroll through the images, sir. It is just getting stuck at one point. 1 second. Yeah. Okay.
Yeah, you can scroll slowly, otherwise it might be very difficult.
Yeah. The images are not moving at all. Okay. So as I'm scrolling through the images, I can see that there is architectural distortion in both the lungs with diffuse centrilobular emphysematous changes. Sir,
I can scroll for you. One sec. I can scroll for you.
yeah.
Yeah. Yeah. Can you leave the mouse once? Yeah.
Yeah, I left the mouse.
Yeah. I think there is a delay in the image
Yes,
scroll.
sir.
Yeah.
So there is diffuse centilobular and paraseptal emphysematous changes I could see. The images are, I mean, like they're really not scrolling at all.
Yeah, no problem, no problem.
I-
So it's basically there is a as emphysematous changes, right? Now coming back to the
Yeah.
X-ray, do you see a pattern to it?
I think they're mostly distributed. So can I see
Yeah,
the
I
X-ray
think
once?
yeah, I'm trying to open the X-ray. I think there was
Okay,
a
okay,
small lag. There is a hand. Okay, I'll do one thing. We'll come back to this case after some time. Let's go to the next case. Yeah. Are you able to see the screen?
Yes, sir. I can see the screen.
Yeah, go ahead.
Okay, I am presented with a nuclear medicine scan. I'm just trying to figure out what scan it is and which body part it is. 0 minutes, 30 minutes, 60, 120, and 240 minutes. Okay, I can see there is an increased radio tracer uptake, and it is, I think it is moving with peristalsis, and I think they are focusing on the gastrointestinal tract. I'm thinking this could be a gastrointestinal bleed. Okay, I think this is I think this could be a gastrointestinal bleed with the peristaltic movement of the radio tracer. So I would like to ask for the history of the patient. What
Patient is
I mean,
patient did not have any history of trauma or abdominal pain. Patient is diabetic.
patient is diabetic. Okay. Okay.
I have one more chart for you on the same case, if that can help you.
Gastric emptying chart. Okay. 90. Okay.
Do you want to go back?
I've been shown with a, yeah, I'm presented with a gastric emptying chart in which time is there on x-axis and retention on y-axis. I'm just trying to correlate these findings.
Okay. Do you want to go back?
I have no clue. Yeah, I don't know what's happening, but I think this is delayed gastric emptying, which is
Okay. Okay. No problem. No problem. Yeah, let's go back. Let's hope that the other see. Okay, this X-ray has not come back. Okay. Yeah, let's fine. Let's go to this case. Oh, I think just give me a moment. I'll just stop sharing for a moment. One sec.